everybody, and welcome to this episode of Blood Matters, a podcast for nurses. I'm one of your co-hosts, Emma, and I'm really excited today to be joined by a different co-host, Hilda. Hi, Hilda. Thank you so much for joining me. How are
Hi,
you?
Emma. Lovely to be here today, and I'm good. Thanks a lot. How are
That's
you?
great. So I'm good. I'm good. So this is not your first episode, but it's our first together, and we're
Yeah.
going to be absolutely fine. I'm sure of it. So this episode we are talking about something more complex, more about complications that can occur in our transplant patients, aren't we? So we are going to be discussing um CLABSI or CRBSI, whatever it is that you prefer to use as your term at the moment. So that would be catheter-associated infections, essentially, is what we're talking about today, isn't it? And we've got
Yeah.
some fabby guests. So I'm going to, I'll just give you guys all a chat about one of our guests, and then Hilda will tell you about our second guest before we bring them on and really start the good content that we've got planned. So our first guest that we have joining us today is a gentleman named Ton van Boxtel, who has an enormous amount of experience, both in nursing and in terms of vascular access devices. So it's 40 years experience in nursing, 25 of which were in the University Medical Centre in Utrecht. He's worked in hematology and bone marrow transplant areas, has a master's degree, he's worked as a clinical nurse specialist, but one of the really exciting two really exciting things that he did. One would be being president of the EBMT nurses group back in the 1990s. Then he pushed to work an awful lot in with vascular access devices, and was the one of the co-founders of the World Coalition on Vascular Access Devices, which was founded in 2009, and he was CEO right up until literally this last couple of weeks when he's stepped down for retirement. So we do wish Ton very good retirement. However, we want to hear what he's got to say about lines today, about catheters. So really excited to hear Ton speak. He's very passionate about everything to do with vascular access devices. So he's going to be amazing, but we're also joined by another amazing guest, aren't we, Hilda? So I'll let you tell us about our second guest.
Yeah, thanks. Our second guest is Christel Janssens, and she is a clinical nurse specialist in a multi-professional team, and that team is dedicated to mid and long-term vascular access at the University Hospitals of Leuven in Belgium. And that team is inserting IV catheters, but it is also responsible for more than 2,000 advices a year regarding catheter-related issues and protocol development and implementation. Christel has a master's degree in nursing science, and she is qualified as a PIC instructor by the PIC Academy network of the Vokova Foundation, which you heard earlier about that. As an advanced practice nurse, she inserts PICs and midline catheters and is developing the first nurse-led PIC team in Belgium. Whoa. Moreover, she's the president of a multi-professional organization called BIVANet, which stands for Belgian Vascular Access Network. Furthermore, she lectures in several healthcare educations, for example, the education of nursing, pharmaceutical science and medicine. And last but not least, she has been given presentations at national and international congresses, and she's the co-author of several publications related to vascular access.
So our guests are pretty expert, aren't they? They've got it all covered. We're going to be able to have a really great conversation today. I'm especially looking forward to this episode, as one of the things that I teach is our central vascular accesses for my patients in the little corner of Scotland that I work in. And so I'm really interested to hear what else people might be doing around the world, and to get some more knowledge on that. And your patients, as a pediatric nurse, will almost all of them will be getting a vascular access device. Is that right?
Sure, definitely. We use a lot of central venous catheters like
Mhm.
Hikmat and big catheters. Yes, all of them will have them.
So we'll be able to share this episode far and wide beyond necessarily just our transplant colleagues. So let's get our guests on and let's get cracking, shall we? So I'm going to extend a really warm welcome to one of our two guests today. We've got Ton van Boxtel joining us. Hi, Ton. Thank you so much for giving us your time this evening. How are you
Well,
doing?
thank you for inviting me.
You're very welcome. And Hilda's got to say hello to someone too.
Hi, Christel. Very welcome to this podcast and happy to have you here.
Hi, good evening. Nice to be here.
So we're really happy to have the guests that we've got today, and the format's going to be just as it usually is. So Hilda and I will alternate asking questions of our guests, and then we'll do our quick fire round at the end and summarize. And then hopefully everyone will have learnt something really cool today on this episode. So I will kick off with Tarn. No, I won't actually. I think we're going to get Hilda to kick off with Tarn.
Thank you, Emma. Yeah, Tom, nice to have you here. And can you please tell us a little bit about yourself and what you do, or what you did, maybe?
Of course, I'm shortly before retirement, but my background as a nurse is in hematology and bone marrow transplant, and that's already from years ago. But I moved after many years. I worked in Munich, and then I moved to Utrecht, and that's where I got hold of the EBMT, the European Blood Marrow Transplant, and was president of the European Group for Nurses. But at some point, I moved to a home infusion program. I worked as a clinical nurse specialist, also on a pain team and on home infusion. But next to that, I started a European and a global group for vascular access in 2009. And I just stepped back from that position as CEO and president since 2010, where we had the first global meeting. And lastly, I introduced PICC lines in the Netherlands in 1997. And I gave lots of trainings and education to many people since then.
Thanks a lot. That's an impressive CV, I can say. So I want to change to Emma.
I'm blown away, and I think we all need to do some more work to get our CVs looking as good as Ton's CV. But we're not here just to talk about the achievements of Ton. We're obviously here to talk about lines and line infections. So first, dead simple question, super easy. What do we mean by eclampsia, Ton?
Well, eclampsia, it stands for central line associated bloodstream infection. And, I think it's better to talk, if you want to use these abbreviations, about catheter-related bloodstream infections, because that's covering the whole area of infection rates and all vascular access devices. So I think it's better than CLABSI to talk about than catheter-related bloodstream infections.
And if I'm honest, when we were preparing this episode, I saw the term CLABSI and went, and I had to go and Google that because I'm used to saying catheter-related bloodstream infections. But for anyone who uses different terminology, we're all talking about the same thing today. So Hilda's got your next question. Or unless you want to come in, Ton, feel free.
No, the thing is that we should all use the same names, and CRBSI is a name, an abbreviation. CLABSI is used very often, but in some cases, and there's a study coming that is going into vascular access devices nomenclature, and I think that's really important to have the same names for the same devices and use it in the same way.
Yeah, that's really
actually
important, Ash.
Yeah.
Mm-hmm.
Hilda and I are both thinking the same thing. That's amazing. So I'll be looking out for that study. Hilda's got your next question though.
Tom, can you tell a little bit more? What is the incidence and why is it such a concern in transplant patients?
Well, the incidence is well, depending on the studies that you look at, but the problem is therefore as long as we put devices into patients. And what we see in practice is that many clinicians and mainly doctors decide first to use up the peripheral veins with chemotherapy and other IV therapies. and then they go to a central venous access device. So I think that is a really important issue that we should try to use to go for the best device at the beginning of the diagnostics and at the beginning of the treatment of the patient, and not first use up the peripheral veins and then go to the central venous access device. I think that is really important. And, the incidence is still quite high. And I think it's also depending on the knowledge and skills of the clinicians that actually insert these devices and take care of them. And that's mainly the nurses.
Yeah, that's true. Emma, I will hand over to you for the next question.
That's grand. Actually just nodding away at that, Ton, because yeah, in the UK we have a group called NEVAS, which is very similar to the group that you were CEO of, that the whole point is vessel health preservation and not being able to predict the future. So we don't know, someone might need some more treatment in the future and you've broken all their veins. That was not the question, Ton, but just so you were aware. What's the impact of a patient getting an infection in their line post-transplant? What can be the impact?
Well, the impact of having a vascular access device need is quite high for patients, and particularly hematology patients and oncology patients. They first focus on surviving. And so vascular access is something that needs to come with it, but it's us that need to take care of, offering the best for the patient. But, patients still suffer because we often don't do the right thing for the patients. And for the patients, it's not priority. So we should make it more priority to offer the best device for the patient and to strive for one access device for the whole treatment. And that's something where the Australians really did a good job, saying that with one poke, you should be able to do the whole treatment of the patient. And that's the Avatar group from Australia. And they do a lot of research also on this matter. But that's something that we should try to do. And I'm sure we cannot always do this. But if I look at one study that we did on the hematology already published in 2014, that's where we saw with a PICC line insertion and using it for the longer treatment, and also later on patients going home with the PICC line, we saw an incidence of infections of 2.1 per 1,000 catheter days. And that's not much. Well, if you compare it to other central venous access devices, but it is something that we still need to reduce even further than what we did so far. And we will go in that a little bit more in the next minutes.
We absolutely will. Do you think then that it should be more of a nursing decision around putting a vascular access device in people and decision about which is the most appropriate?
Well, the decision is it's for the team, the care team, and that's the physician and the nurses. And in most countries, it is the physician that decides on what to actually choose for as the best device for the patient. But what we see is that physicians often don't really know what is there on the market, how to do it. And overall, you can say it doesn't matter who is putting in the device and taking care of it, as long as you have the knowledge and the skills to do it the right way. That's where we should go for. And, that's where nurses can play a huge role. And we see discussions in many countries where nurses don't really step up in taking this area for themselves. And that is probably one of the messages for the nurses within the EBMT to pick this up and take more responsibility for vascular access.
I completely agree. Absolutely. Hilda, you have the next question.
Yeah, it's clear that we have to take our roles. So what measures should we adopt to avoid catheter-related bloodstream infections more, and where is the strongest evidence for that?
Well, the first thing is good hand hygiene and hygiene overall. And I think if you have a sterile procedure, you should really do a perfect sterile procedure. You know, this week I had one example where I saw that a peripheral venipuncture was done, and then a gauze was actually folded on the leg of the patient that was doing the venipuncture, and that's something where you increase the incidence of infections. So that's one reason is to have the best hygiene that you can offer. And, you know, if you look at the evidence, what is needed to look at, then I can say studies published in the journal Vascular Access should be taken care of and read, and, you know, the structure. And I read one study where they looked at the incidence of infections and thrombosis on PICC lines, but they didn't compare it. And so you have to compare with what you did before. And otherwise, it doesn't make sense just to look at the incidence of, let's say, PICC lines, although that's a very good option for hematology patients because you have a central venous access device that you can use for a long time. Patients can go home with that, and you can pull it out if needed. So, and of course, you should not pull it at the first sign of maybe an infection that comes from another area. But still, it is something that is easy to insert. Well, relatively easy if you know the skills and knowledge. But on the other hand, it's easy to use and easy to take away if there's any problem. Other evidence is I would recommend to look at the INS Standards of Practice. That's the Infusion Nurses Society Standards of Practice 2024. There is the new standards published, and they renew it every 3 years. And there are many good references actually supporting the statements. So that's what I would recommend.
That are very helpful suggestions of you, Ton, and I think we would have a lot of more of questions to you, but we also have Christel with us here, so we also want to change to her. And Emma, the next question is for you.
I do. I'm going to say hello, Christel. Thank you so much for joining us and for your patience in that. We're going to come back to you, Ton. Don't disappear because we're going to do the quickfire round just after we've had a chat with Christel. So first of all, Christel, could you just tell us what you do? What's your role? What's your interest? Because you are also very involved in vascular access.
Yes, indeed. I'm 40 years old and I'm working in the biggest hospital, university hospital of Belgium. And I finished my master degree in nursing in 2006. And my thesis was around the first PICC lines in Belgium. And after I finished my master degree, I started working as a nurse in the anesthesiology department. And I worked there until 2011. And then I started in 2009. So I combined both jobs a little in the beginning. I started as a clinical nurse specialist in the vascular access team in our hospital. And our team is in charge of organizing all the long-term vascular access in our hospital. And it starts from the selection of which catheter for which patient, but also the insertion, the removal. And we also give more than 2,000, I think, advices a year regarding catheter-related care and complication management. So in 2011, I followed a special training in Italy to become a PICC inserter. And since then, I am inserting PICC and midlines myself, which is not that obvious in Belgium because in Belgium, nurses are not allowed to insert those catheters. It's
Wow.
just a thing for physicians to do.
Okay.
So in 2014, I think, I followed a training by the PIC Academic Network and the World Congress on Vascular Access Foundation, of which Ton was the CEO, to become a PIC instructor. And then I trained some nurses to insert PIC and midlines as well. Although we were not allowed to do so. But since, I'm very glad to say this, the 24th of April, so it's very, very new, the law in Belgium changed, finally. So now our PIC team will be legally regulated after more than 13 years of doing things that were illegal. Now everything is going to be regulated. So I'm very glad that this happened finally, pushing a lot of boundaries broken, and now we are going the right way, I think.
I think that deserves a congratulations, because that is a lot of work to get to that point. And you shocked me, because years ago I was PIC inserting, and I just assumed every area would be the same, but no. Well, like I say, congratulations. Thank you for that. It's really interesting. You are another clinical expert. So Hilda's going to ask you the first real good question about lines.
Also, congratulations from my side, Christel, because it's a huge achievement, I can say. So can you tell us a little bit more, how do you see nurses embedding the best practices in line practice? And is there more that it could be done?
Yeah, I think every hospital needs a specialized IV team, just to make sure that they put into evidence-based protocols, not we're doing this because we're used to do so, or somebody read this or that. No, everything has to be evidence-based, and it is needed that a specialized team is taking care of it. So they can educate all healthcare professionals in the hospital how to do so, and especially nurses. What do they have to do, what they better don't do, and also explain how and why they have to do certain things. We can help them to look for solutions for challenging problems with catheters, and also train nurses to take care of vascular access. And as Don also explained earlier, it is important that we are allowed to also insert catheters, taking care of the management, have some decision in taking in how the team is working around the patient, and have some a key role to play, because as nurses we care for the patient, we use the catheter, we see what their problems are, we hear what patients tell us about what they are struggling with. So and all those things you can take into account to make a decision which catheter might be the best catheter for those patients at this moment, for the treatment they are getting, and also how to insert a catheter. So the maintenance will be more at ease, less troubling, less irritating for the patient as well. And I think most of the times now it is mostly the physician who is taking all the decisions and who is dependent on what is going to be done. And let's be honest, not all physicians are that dedicated with vascular access. It's something they do between two large surgeries, and because they have to, but they are not really interested in it. And nurses, they are much more dedicated. If you have a clinical nurse specialist in vascular access, they are dedicated to do it very well and take everything into account, and also hear about it. I did something wrong. Maybe I can do it better next time if I take this or this measure. So I think that is an important thing that we should take into account. And nurses, really step up and take your role in this decision about vascular access, which one we are choosing, how they are inserted, how we are managing, how we are solving complications, all those things.
Thanks for this wonderful answer, Christel, because Ton and you both plea for a huge role of the nurses and taking their roles. That's really nice to see. I will head back to Emma.
So when I was, thanks you for that also fabulous answer. We're very pushing the nurses today because, well, we're
Yeah.
all nurses. Um, so when I was looking into you as a guest, Christel, I was looking at quite a lot of your research and published work that you've got that we can see about complications. So I've got a sort of two-part question here. So do we know, are there any recognized links between catheter-related infections and other complications associated with the catheters? So, possibly things like thrombosis or
Yeah.
occlusions. And then, where do you see care bundles in preventing, assessing, or treating line infections? So it's a
Yeah.
two-parter.
Yeah. So if we look into infections, yeah, and thrombosis, they are linked. Sometimes it's not really clear which one was first.
Mm-hmm.
If you have an infection, there are some things in our body are going on who might increase the risk for thrombosis. But if you have a thrombosis, those blood clots are also a good source, a good environment
The
to grow
bacteria.
in. So which one was first, and the one will be adding risk to the other one.
Mm-hmm.
So I think you have to take both into account when you look at infections or if you look at thrombosis. And also thrombosis can cause, of course, other complications for the pulmonary embolism. Also, some parts of the thrombosis can come loose, and if there are bacteria in those clots, they can travel around the body and cause complications somewhere else. Also, the patency and a catheter that is not functioning well, that might also be caused by a thrombus at the tip, for instance. If those tip thrombus also gets infected with some microorganism, most of the times the tip of the central lines are near the heart. So if you have an infection there, that also might cause endocarditis or something like this. So sometimes we look at the catheter infection. Is this really that bad? Yeah, it can become bad. It is a dangerous complication. And most of the times we are looking at central lines, but it is important to mention that it's not only the central lines. Also, a peripheral line is in a blood vessel, and it also can cause infections. And most of the time they are overlooked. We're only looking into the central lines. And so it is no problem to poke patients over and over again with a peripheral line. If there is an infection of those peripheral lines, you also can have a very serious infection or an endocarditis. It's not just the central lines only. So I think that is one thing that will be going up the next more years, to have more attention for those peripheral lines as well as a cause of infection, and maybe put some prevention strategies as well. And then you also had the second part about the bundles. Yeah, I think the care bundles are a very good help to us. Most of the nurses know what to do, but there are a lot of things that has to be done for a patient during the rush of the day and all those things. Are we sure we have checked everything? Is everything really okay with the catheter? Not just have a small look at it and it seems okay. No, we have to check if the insertion site looks good, if the dressing is properly on the catheter, if the catheter is working properly. And the smallest thing that is not right, if you cut it soon enough, then you can prevent that larger, more serious complication can happen. So I think those bundles will help us to do better, to have better outcomes, and make sure that a small problem doesn't become a bigger one. And I think it's a simple thing, those care bundles, just to help us. It's a tool and not some box that has to be ticked. It's not extra work. It's a tool to help us to remind some things and not to overlook small things, I think.
You're essentially preventing extra work if you do the bundle or the documentation
exactly.
because you're reducing that risk of infection or occlusions. And there is literature out there to show that if your documentation around your line care is as good as it can be, then you are seeing less complications. So I'm very glad that we're on the same page about this, Christel. We're all on the same page. So Hilda's got your next question, so I'm going to hand you back over to Hilda.
Thanks, Emma. Yeah, Christel, you already told us a little bit about the short-term complications, but can you tell a little bit more about the long-term risk associated with these kinds of infections, especially in our immunocompromised patients?
Yeah, immune-compromised patients, that is a very specific group because, the infections are picked up a bit late sometimes, because the first things you will have to see, like fever or maybe some pus around the insertion site, you might not be seeing in those patients because they're immune compromised. So you have to be very sure and be very attentive for the signs, the symptoms you see, but also, if you wait longer for treatment, for instance, with antibiotic, you have a higher risk that they become resistant to, and you have more serious bacteria surrounding in the bloodstream of the patient, and more difficult to treat in the future. So that's a difficult one. And immune compromised patients, if it is a long-term treatment, they need a lot of catheters. Hopefully they don't need a lot, but if an infection happens, you have to take the catheter out, you have to put a new one in. In terms of vessel health, that is not a good thing to do. If patients are young and get very ill, hopefully, because our healthcare is improving a lot, people live long, and hopefully if they get to 70 years old or maybe older, they have still some vessels we can use. So we have to make sure to take good care of those catheters to prevent troubles in the future, for putting just a small IV in to get some fluids, or maybe do a blood sampling to check if something is else. If you use all those veins, you don't have anything left to take care of the patient in the future. So I think that is also an important thing to take into account.
Really important lessons, Christel. Thanks a lot.
So this is what we call the quickfire round. So these questions are just designed to give you give us your instant answer, your instant response that comes into your mind. We've just got a couple for today. And I think we'll start with Ton, and then we'll ask Christel the same question. So Ton, what is one simple thing that we could change to improve the outcomes of a catheter-related bloodstream infection?
I would say it's the team approach, and it's not only the inserters, but also other people on a team. If we agree on what a team is meant, team of experts in inserting, and inserting not only peripherals if it's difficult, but also central venous access devices, including PICC lines and other devices in the jugular, for instance. But that's, I think, something that should be a direct team of experts in inserting all types of vascular access devices. And next to that, that management and, for instance, also pharmacy and others are all also taught on what the importance is of vascular access for those patients. I think those two issues are so important to improve outcomes.
Totally agree. Your team makes life easier, doesn't it?
Yes.
Same question to you, Christel.
Yeah, I think it's important to make sure that there is really something going on with the catheter. What I see a lot in our hospital is the patient has an infection and there is a catheter in, pull them out. And then the patient needs another catheter. And maybe there was an infection, but there was nothing wrong with the catheter. So we have, if the patient is stable, let's just check if the catheter is the cause. Take some cultures, compare them, and look at the microorganism that get it out, check the differential time to positivity. And if all is indicated that the catheter is a problem, then take it out. But not just pulling it and then, what are you going to do now? that's not the good insight. And that's a STEAM approach, what Ton already said. Yeah, make sure not the treatment team is working only together, but also have something with IV knowledge from infection prevention and talk with each other. And not just calling one of them and they say, oh, an infection, pull the catheter out, and the other one is saying, no, save it, let it in. Talk with each other and then decide what is best to do for the patient.
So I suspect that might also be the answer to our next question for you on the quickfire round, but let's find out. Hilda's going to ask you guys the next quickfire question.
Yeah, I will first start with Ton. And what is one opinion you want to challenge about catheter-related bloodstream infections?
Well, I think the big challenge is knowledge, skills, and good care for the patients that go through a very difficult period in their lives. And I think that's our role in preventing infections and other complications like thrombosis and occlusion, for instance. We didn't talk about occlusion, but I think that's also an important thing to prevent. And that's where nurses play the most important role in taking this area to themselves, but only based on their knowledge and their skills and their way to communicate and take care of the patient.
Thanks a lot. And Christel, same question for you.
Yeah, there are a lot of challenges if you look on catheter-related infections. I think what I hear most of the time, there is a shortage of nurses in a lot of hospitals. So I think we have to embrace technology that can help us to lower the workforce for nurses. There are some AI things developed on how to look at what are our high-risk patients, which patient we have to be more taking care of take an extra look at, maybe because they are more at risk for an infection, and maybe we can add some extra prevention measurements to take, because everything has a cost. We cannot put all catheters with an antibiotic lock, or all patients have a special dressing that is a prevention strategy. It costs too much. Hospitals can't pay this, but maybe we can use technology to help us to pick the right patient and say, oh, maybe we should do this, and then make sure our nurses get the right material to improve their outcomes. Maybe that will be a good idea with all those new technologies that are around. Let those things help us in what we are doing every day.
Yeah, I totally agree. Let's use those technologies when we have sometimes to learn to do that more and how to increase that knowledge. But yeah, thanks a lot for these wonderful answers. I think we have come to an end of this podcast, Emma. Do you have any questions left for Ton or Christel?
It's always one when you put me on the spot. Have we got any questions left? There's nothing left on the quickfire round, which is great. I think something that's came to mind on something that Christel said was possibly there's a place for like an intermediate type line like midlines in certain circumstances, especially if you have to pull the catheter, if it is appropriate to pull. And then you're looking at, cannulation every 72 hours, which is quite stressful on the veins. Perhaps some areas that are not using midlines, that's possibly conversation to be had. And you're right, Tom, we didn't talk about occlusions. Maybe that's the next episode on catheters, is about prevention of occlusions and the impact that would have on our patient group. But we'd like to say a massive thank you for the two of you to joining us today. It's been a really great conversation. And if you want to add anything else to it just now, please feel free. If you've got anything else to say.
Sorry, there's one thing I want to add is that the choice should be the best for the patient and not the best because nurses are allowed to place midlines that inserters are using a midline preferably, but it should be the best device for the patient and the treatment of the patient, and not because the organization is saying, you know, nurses can only place midlines. That's I want to add.
Yeah, that's why we were going for PICC lines, although we weren't allowed to do so. And then midlines in hematology patients, we sometimes use it for lymphoma patients, which normally we would want to insert a central line, a PICC, a tunneled catheter, but the lymphoma is pressing the vena cava superior. So we can't get in. And what we are going to do now, we are not going to poke the patient every time we have to take a blood culture, or every time we have to give something. No, we put the midline in until the tumor is shrinked, and then we can put in the central line. So it might we can't get the first line, the most appropriate line. We can't get in because of the patient's circumstances. But then after a while, we can do it with 2 catheters instead of maybe 10, 15 catheters.
So we're saying it's bespoke for the patient, which is always the point, isn't it? About person-centered, realistic care that is very much about the person at heart. So great final point, Ton and Christel. Thank you very much.
Thank you so much from my side as well. Wonderful.
Well, thank you for having me and us to share some of our thoughts.
We could be talking about this for hours, but I don't think we've got time this time round. But thanks for joining us.
Good evening, everyone.
Joining.
Bye.
So we are at the end of this podcast, and we had 2 wonderful guests, Ton and Christel. We got a lot of insights of both of them regarding central venous access. We must say that instead of lines. We learned it today. Ton and both also, Christel told us a lot about the nursing role in the catheter-related bloodstream infections, and we have to pick up that role, and not only in preventing infections, but also in preventing thrombosis and occlusion. And I think we can talk for hours about that.
Always so good.
Yeah, that was so good. And Ton pointed also out that the INS, the Infusion Nursing Society, has their latest standard in 24, their 9th standard. So Ton referred to that, and we put all the links of these standards in our below our podcast, so you can look in that. So Ton and Christel, thanks for today and for all your insights. I think we have learned a lot, and I'm sure every listener will also learn a lot. And thanks for listening today for all listeners, and also thanks for the technical team. And thank you, Emma, for being a wonderful co-host.
That's grand. Thanks for having such a fun episode for our first one together. I look forward to the next time we get to do it together. And enjoy it, guys. If you've been listening to it, please share it far and wide. Take care.